Once you start to have some airway collapse, maybe there's the back of the throat, maybe on the soft palate or the uvula or the adenoids are starting to relax or the tongue is starting to fall backwards and start to limit that flow, then it starts to show a different morphology or different shape of the flow pattern. Now, when you're going into your lab and you see a pattern that's like this, understand immediately that these are already flow limited breaths. And typically, some of these patients, if you see this and they're still awake, that means they're pretty bad on the what scale is that when you ask the patient to open up their mouth and they go, what is that called? Starts with an M, Pati, Mallampati, Mallampati. So usually ENT doctors that are also sleep boarded, they always look at that. And also some doctors who have surgical background, they always look at that. Not all labs will ask you to do a Mallampati, but usually when they do, the doctors are also there. They'll come in and assess the patient and then they'll put it's one page typically. They'll identify whether this patient is one, two, three, or four. Four being no, you won't have any opening at all. So when you have patients that they go and you can't even see the back of their throat, you just see their tongue, then that patient is pretty severe. Patient's already having blockage even before they actually fall asleep. All right. So RERA is now hypopnea. Now sometimes you'll see flow patterns and they go way beyond the normal flow pattern or when they do recover, but then they go beyond. And what is this typically when you see this flow pattern? They go way beyond the baseline. So the baseline is here. You have an imaginary baseline. Why do you think is that? What is this? What is this feature typically on PAP devices that will allow for this to happen?
EPR, or pressure relief.
Very good. EPR is one. Okay. So anybody else? EPR. What else? So it could be EPR. It could be also C-Flex. Because when you say EPR, that's ResMed. C-Flex is Philips. Then they also have things soft PAP with Fisher and Paykel. And so you have to look for that pressure relief or pressure release. It's when the CPAP is giving a pressure and when the patient exhales, it drops the pressure slightly. And typically you have a setting of 1, 2, or 3. 3 settings to drop the pressure, to allow the patient to exhale out a little bit more comfortably. All right. And what is this? Don't tell me it's an Apple Watch. Could be. Has the name there too. I should have covered the name because I'm not marketing for these companies. What is this? This is a
Wearable watch.
Okay, good. So I hear some home sleep studies, wearable watch, but this is an example of an actigraphy. Okay, so most actigraphy, in fact, right now, the most common actigraphies are your watches, the smart watches, right? You have Apple, Samsung, Amazfit, all that. All of these devices now, on the phone, it's on the watches, it's even on the rings. There are some that are only bands and they're all for actigraphy. But this is the report that we saw earlier. This is pretty much the source of that report. It can show patients' activities throughout the day and night. So if the patient wears this for 2 weeks, you'll be able to identify whether the patient has a good sleep hygiene, whether the patient has a regular sleep pattern. In a sense, those patients that are exhibiting some form of insomnia, they might have irregular circadian rhythm pattern. They might have delayed phase syndrome or early phase syndrome. It helps a lot just understanding the download and the sleep log for not the non-OSA patients. However, even when I mention non-OSA, some patients actually have a combination of both. They will have insomnia and they will also have OSA. What is that called? Our patients call, or what diagnosis is given to patients when they have both insomnia and OSA. COMISA, right? Complex insomnia, there's a very small prevalence out of the obstructive patients, but they do exist. Some of these patients, they will present first with obstructive apnea, and so they will be treated with PAP therapy. So once they are on PAP therapy, eventually they start to again not do well on PAP because then they can't sleep. What usually happens is when they present first with obstructive apnea symptoms, they're sleepy and they snore, they stop breathing. So now they get into treatment. Once they get into treatment, the obstructive sleep apnea slowly goes away or is reduced to normal values. Then what happens next is the insomnia surfaces. So when that happens, these patients will require both. They will keep their PAP therapy, but they'll also start their CBTI. They can be placed on medications and be given behavioral changes or behavioral modifications to improve their insomnia. They can be given additional medications or not. All right, there's a few more questions. What am I looking at here? What are we looking at? This is first a PVC. However, there is a pattern. So now it's not just a PVC. This is every other abnormality. When it's every other abnormality, then this is a bigeminy. When the abnormality is every third pattern, then that's a trigeminy. When it's every fourth abnormality, then that's a quadrigeminy, okay? But earlier we identified two PVCs together. They was one after another, so that's a couplet.